I can only imagine that OIC can easily be misdiagnosed and identified as irritable bowel syndrome, Crohn's disease, diverticulitis, and a host of other conditions. In fact, there are nearly 10 other conditions that can make diagnosis of OIC difficult. So how is differential diagnosis of OIC made in practice?
Well, OIC is a diagnosis that seems to fit with what the current situation is for that patient. Patients with history of opioid use and the timing of their constipation generally match. When they discontinue opioids, if they stop it, it generally resolves. But for the patients that have to take opioids on a regular basis, that may also have these other GI-related conditions, it's important to be able to understand what it may be. And you may look at imaging, like x-rays or CAT scans, to see the presence of stool there. You look at the history of how often they're able to go and have a bowel movement, or what sort of experiences are they having during that time. A lot of irritable bowel may be constipation mixed with diarrhea, cramping. Some of these patients in OIC are having less than 3 bowel movements in a week, or they talk about sitting on the toilets for long periods of time with nothing really happening. They feel this constant pressure in their stomach, almost to the point that it's very hard. So yes, there is always a differential to consider, and obviously we want to make sure that it's not something very dangerous to miss, like a cancer or so that's preventing the stool from passing. But practical things being practical, you probably can judge based on the timing and utilization of the opioids that it probably is this.